It was right here in 1891 at the University of Prague at the Institute of Pathology, where the late Austrian pathologist Hans Chiari published a paper in 1981 which described hindbrain anomalies in autopsy specimens of children with hydrocephalus and spina bifida. In 1894, Professor Julius Arnold, the German pathologist, also describes a single case of hindbrain herniation in children with spina bifida. It wasn't up to about 60 years later, with improvements in neurosurgery, that clinicians began recognizing Arnold Chiari malformations in children with spina bifida and hydrocephalus, and the term Arnold Chiari malformation was born. Greetings, hello, and welcome. Today, let's take a look at the Chiari malformations, what they are, where they come from, and how to manage them. First, the big picture. Chiari malformations are structural defects at the junction of the skull and cervical spine. They occur when parts of the cerebellum and brainstem are displaced downward through the foramen magnum. The two most clinically relevant are Chiari I and Chiari II malformations. Chiari I is defined by herniation of the cerebellar tonsils, often due to a small posterior fossa. Patients may present later in life with occipital headaches, neck pain, or syringomyelia, though some remain asymptomatic. Chiari II, also known as the prototypical Arnold Chiari malformation, is more severe and congenital. It involves caudal displacement of cerebellar, vermis, brainstem, and fourth ventricle. Almost always, it is associated with an open neural tube defect, such as myelomeningocele. Importantly, Chiari II is not just a severe Chiari I. It is a distinct malformation with different developmental routes. What is the embryology? Several theories exist. A widely accepted idea is the small posterior fossa hypothesis, where the underdeveloped skull bones compress hindbrain structures. Other models emphasize disrupted cerebrospinal fluid flow during early neural tube closure or mesodermal defects, affecting both bone and neural tissue. These explain why Chiari malformations are so often linked with myelomeningocele and hydrocephalus. Chiari I often presents in adolescence or adulthood with headache, neck pain, or syrinx-related symptoms, meaning dilatation of the cord symptoms. Chiari II almost always presents in infancy with myelomeningocele-related spinal signs, hydrocephalus producing a bulging fontanelle, irritability or poor feeding, and lastly, brainstem dysfunction, such as swallowing difficulties, stridor, or apnea. Management depends on type and severity. In Chiari I, asymptomatic patients can be observed with regular imaging. Symptomatic cases, especially with syringomyelia or progressive neurological signs, often require posterior fossa decompression surgery. This involves suboccipital craniectomy, sometimes with duroplasty to enlarge the foramen magnum and restore CSF flow. For Chiari II, management is more complex, as it is usually detected at birth along with a myelomeningocele. The first priority is closure of the spinal defect, ideally within the first few days of life, to prevent infection and further neurologic injury. Hydrocephalus is treated with a ventriculoperitoneal shunt, or in some centers, endoscopic third ventriculostomy with choroid plexus cauterization. If there is severe brainstem compression causing feeding or respiratory compromise, posterior fossa decompression may also be performed, though results are less predictable than in Chiari I. Multidisciplinary care is essential. Neurosurgeons, neonatologists, orthopedic surgeons, and rehabilitation specialists all play roles. So, to summarize, Chiari I is usually managed with monitoring or posterior fossa decompression if symptomatic. Chiari II requires urgent closure of the myelomeningocele, CSF diversion for hydrocephalus, and selected decompression for brainstem compression. Both demand a tailored, patient-specific approach, often involving long-term follow-up. So, when you think of Chiari malformations, remember, it's not only about what's herniated, but also about why it happened, how it presents, and how timely interventions can improve outcomes. Thank you for listening and have a blessed day.